Okay, so let's get going. Canvas is down. Class is ended early. Let's go. So I'm just going to be talking off the PowerPoint, and we'll do some questions and evolve. But we'll pick back up with the sexual disorders. Again, this is chapter 20 in your book, and in your syllabus, you notice there's some different meds in this category that you haven't had before. Testosterone. What are some of the side effects from taking testosterone? Yep, hair, all the side. So, and then also your Viagra type medications are the new groups. Testosterone is on page 390 in your textbook. Used for numerous reasons in this chapter. Both sexes need testosterone to function appropriately sexually. It's also used with people with gender dysmorphia if they're trying to transition in gender, especially from female to male. A couple other page numbers of importance. Page 386 is some of the medical causes of sexual dysfunction. And so we kind of also mentioned, having to ask these questions, and sometimes as a nurse may be uncomfortable. Just remember, yours is professional, and these are issues that people may need help with, and so you approach it in a professional manner. And always remind the client that you're going to keep your information confidential, unless, of course, it was some sort of get where I was. Okay, we're talking about paraphilias. That's on page 394 in your book.
94?
94. Mm-hmm. And again, these are usually disorders with unusual or bizarre sexual imagery or acts. And they have to carry out these acts to achieve sexual excitement. And we said they involve non-human objects suffering or humiliating someone, or involve children or non-consenting persons. So that's when you're getting into pedophilia.
I was wondering if it was part of that.
Characteristics of paraphiliacs: emotional insecurity, fear of a sexual relationship that might end up in rejection, and again, y'all, these are general characteristics of this. Some of the things that contribute: they may have shyness, or they need to prove masculinity. All the way to the other end of the spectrum, they may be wanting to cause pain or hurt somebody else. And they may need to do that in order to achieve sexual satisfaction. Or on the reverse end, they may need to feel pain or to have sexual satisfaction. Low or poor self-concept, and depression. Another issue that you may see in mental health with sexuality is sexual addiction. And it affects about 6 to 8% of the population. It's not more than most of those personality disorders. And it's engaging in obsessive compulsive. Remember, obsessive compulsive, got the obsessive thoughts coming in, and then you have the compulsive behavior to help relieve the anxiety. So this is obsessive compulsive sexual behavior. And it causes severe stress to the individual and their families. The addiction to sex is just like an addiction to gambling or anything else. The sex takes a priority over family, friends, work, and their values. So that's where the problems come in. Also, that second to the last slide is principles of a sexual assessment. Be empathetic, be comfortable and at ease, present an open attitude, accepting, with any assessment, you're going to want to ask open-ended questions to get more feedback and to encourage them to explore their, well, how does that make you feel, or is that working for you, or how is that affecting your significant other? But sometimes in an assessment, you may need to ask for specific questions that do end up in a yes/no. So more than just therapeutic communication, you may need to ask, have you ever had any medical condition? Well, that's a yes/no question, but that's in assessment. Therapeutic interventions, they may benefit from group or individual therapy if they have a disorder. And some types of behavioral therapy, cognitive behavioral therapy, where you're trying to change those maybe compulsive thoughts and change the way they're thinking so that they can change their actions and cut down on the any inappropriate behavior. If it's something like pedophilia, there is an intervention that they may end up in prison. So, or if it's rape, they could end up in prison. Many sexual disorders are treated just on an outpatient basis. So tomorrow, when Candace is up, we'll look more at the syllabus, but make sure you're looking at those new med groups. What do they do? What are their major side effects? Any red flags with them? And what the clients can expect when they're taking it. So here's a few questions pulled up. Any ball? When attempting to determine the cause of low sexual drive, we talked about this, either male or female client, the nurse can expect to draw which level? Okay. Page 3, they reference page 382 in your book. A client reports symptoms suggesting a sexual arousal disorder. The nurse appropriately assesses this client for a possible cause by asking, when did this problem first occur? Is there a specific time of the month when this problem occurs? Are you allergic to any particular foods? Do you take any antihistamines? Let's try B. See what it says. Antihistamines. The anticholinergic effects. But we didn't cover that. That's not specifically listed, but it does go back to the fact that there can be a medical issue going on. So you need a really good list of any medications they take. They may be having, so that's why you need we talked about a good thorough medical exam and a good background, because they could be talking to you and all upset about the sexual function and all, and you ask them, are you on any prescriptions? Well, no, but if you didn't ask if you're taking something over the counter, well, if you're taking an antihistamine every single day for your sinuses, that could be something really contributing to it. So it's just a good way of understanding how it's important to get that complete background of what's going on with the client. 18-year-old male reports difficulty maintaining an erection. Well, we didn't go over this, but the nurse appropriately assesses the client by inquiring, when did it begin? So we can just practice your test taking skills. How does the idea of sex make you feel? Have you ever had your testosterone levels checked? And are you aware of the history of this problem among males in your family? They're all pretty good. Let's see.
At that age, that's when the problem came.
A, C, and D are all looking at medical issues. B is the only one that's looking at a psychological issue, a thought issue. So let's try B, because they're young. This is an 18-year-old. It's rare for a young male to have dysfunction. So asking maybe a cognitive mental health question may be more appropriate with this client than going straight to some sort of a medical issue. Okay, this is a good one. The most beneficial nursing intervention directed towards minimizing the discomfort associated with conducting a sexually focused assessment is to assure the client it will be kept confidential, provide the client with a reason or rationale of why you're asking the questions, begin with the most relevant, non-personal question, project a relaxed, casual demeanor when questioning the client. So this is the most beneficial. They're all good. Let's go with A. Tell them why you're at a desk. The initial task of an outpatient clinic nurse who is working with a client experiencing a sexual disorder is to do what first? Yeah.
Takes time to do.
I pulled these up on the cameras right there. Syndrome that occurs after stopping the long-term use of a drug is called what? Withdrawal. Yeah. Let's move into the substance abuse. Okay, so chapter 22 in your book. Okay, so we're going to talk about substance-related and addictive disorders. We're talking about several things in this unit. Legal things, like alcohol, that are legal, perfectly legal, and but can lead to some of the most problems. And then we're also talking a little bit about illegal substances and addiction to those, and then the goals of treatment. We'll also touch on your responsibility as a nurse with addiction and substance abuse, and we'll go over that at the end. The goal for treatment with someone that's addicted is that they stop using whatever substance it is. All right. Wish I had. Okay, so if you look on, let's see, slide 1, 2, 3, 5. This starts with some definitions. And the first one is intoxication. And that's using a drug or a chemical to an excess. So. And then tolerance. Tolerance is our ability to use more and more of a chemical over time. We build up a tolerance. Somebody who never has a drink can drink one glass of wine and be intoxicated. And someone who drinks every day can drink a bottle and not be intoxicated. So tolerance. Withdrawal is physiological changes that occur when your blood and blood and tissue levels of a substance decrease. After a heavy or prolonged use, you start to withdraw. An addiction. You can overuse alcohol and maybe have a disorder, but it's temporary, you can stop. But then addiction is when you can't stop, you need help to stop, and that's with any drugs or alcohol. It's characterized by a loss of control of the substance consumption. You can't control it anymore. You used to we end up talking about alcohol the most, but remember this is just anything. But the difference is you could casually have a few drinks before, but now you can't control the consumption. You know you shouldn't be using the drugs tonight because you're supposed to be at work tomorrow, but you can't control the consumption. You knew you shouldn't be spending your last bit of your paycheck to buy whatever it is, but you can't control the consumption, so you do. So that's the difference in that with the addiction. It's causing you health problems. It's causing you problems with your significant other, but you continue to use the substance. You manage to stop for a little while, but you tend to relapse. So those are kind of the characteristics of addiction. When you're like screening for addiction or usage, some of the key questions that you will ask is in the last year, have you drank or used drugs more than you meant to? And have you felt you wanted or needed to cut down on your drinking or drug use and you couldn't? So those are two of the key screening questions for substance abuse. So your assessment, attain a history of the patient's substance use. How much a day? Explain to them how much a drink is. You can't just go to anybody and say, how many drinks do you have a day? One, well, how big is it? A liter. So you gotta clarify the size of the drink. And I have a video, and if I can get, it was in Canvas, but it kind of breaks down. So before you're screening or you're doing the questions, you explain to the client a drink is like one beer, 2 to 3 ounces, I can't remember how much for sure, in one.
1.5 ounces of distilled spirits, 5 ounces of wine, or 12 ounces of beer.
Thank you. So you want to clarify that, and you want to ask them what their history is. How much are they drinking every day or every week? You want a good medical history, so it can let you know if it's impacting anything else going on with them, and a psychiatric history. We've already talked about a lot of conditions that people may self-medicate.
Scary wants to know when we're going on break.
Huh?
That's scary. She asked me when we were going on break.
door being around here.
Are they gonna get a break or have they just got back?
We just got back.
Oh, that's fine. I
started.
just wanna ask you a question.
Okay.
This thing on the bid first,
Uh-huh.
how many students does that affect? All of them? Okay, so when you come on.
Oh, they're gonna be changing our schedule units out. You can't, this won't work now. I can't get it open. Web services either, nothing. Just hit the spin, go to blank page. Because I was gonna look at that stupid thing to write them papers and I can't even pull that up.
It works. The app works.
But on our computer it won't work. Huh?
Sorry.
Y'all have the app on your computer?
Yeah, I know. I'm on campus, regular internet. Yeah.
Oh, it
Campus
won't come
is
pull up on mine.
working on some people, so maybe.
I can this anytime. The one time I really wanted to play some videos that I hadn't done in home.
You want to use mine with mine?
No, I could look it up, but I just wanted to go straight to the link. It's just not pulling up. Okay. Okay. So going on with addiction. Psychological changes you're going to see with someone when they're addicted is denial. Well, it's really not that bad of a problem. It's really not causing many issues. Depression. Anxiety, low self-esteem, hopelessness. And when you hear hopelessness and low self-esteem, what are you want to make sure you screen? Suicide. And if it's and having the extra chemicals on board, having what, especially if it's alcohol, which is a depressant, or the drugs on board, impulsive behavior can go up. You know, especially with alcohol, it limits your inhibitions, and so if they're at risk for suicide and they're drinking, they're really at risk. So you want to do a real good screening. And abuse of drugs and alcohol, like we said, are linked to various mental health issues. Bipolar disorder, depression. We just talked about schizophrenia has a high rate for dependency. So they will need a very good assessment. Signs of alcohol intoxication. The whole brain is affected by alcohol. They're easy to anger, staggering, feel fatigued. If you have somebody come in, I'll just get around the video. If you have somebody come in who is intoxicated with alcohol, and you admit them to the unit for withdrawal, that's kind of a specialty unit in the hospital, an alcohol and drug unit. If you don't have a specialty unit for withdrawals, and you're needing to withdraw somebody, most of the time, for a little while at least, they're managed in ICU. Withdrawing someone from benzodiazepine or alcohol can be life-threatening. So, you're going to have them in a closely monitored area. And if you're gonna go ahead and withdraw them, you go ahead and do an evaluation. And there's a screening tool that most hospitals will use to screen for withdrawal. It was just like with suicide. You know how we talked about, well, are they at risk for suicide? And it's real subjective. Same way with withdrawal symptoms. You would have a client on the floor and you would start to see some signs and symptoms of withdrawal, maybe some tremors in their hands, sweating, or hallucinations, whatever it may be, whatever signs and symptoms we assess. Then you call the provider and you're like, we see it looks like they're withdrawing. And then there was just a whole different ways that they might manage the withdrawal. This provider might do one thing and this would do another. But they've kind of standardized that screening too. And usually most hospitals have a screening tool. What type of physical symptoms do you see? You add up your score and you get a total. And then when I call the provider, I'm like, well, I did the withdrawal screening and I got a score of this. And then there's a set of orders that go along with that screening tool. Well, they scored a 10, so they'll tell you, go ahead and implement these orders, and then it walks you through what you need. The problem with alcohol withdrawal, especially if it's been a lot of alcohol for a long time, it binds with GABA receptors. GABA is another one of those neurotransmitters. Okay, so we're back to neurotransmitters. Alcohol kind of binds to where GABA usually does, and it does its work on the neurons there. So for a long time, this person's brain has alcohol working in the brain kind of like GABA neurotransmitter. Then all of a sudden, you take that alcohol away. The body is like,
Freaking out.
yeah, where's my receptors? Where's my receptors? And it floods your body with GABA, with neurotransmitters, trying to fill this gap. And that's where occasionally you'll get somebody that ends up with delirium tremens, coma, and death from alcohol withdrawal. So that's why if you have somebody, like I've literally been in the weight room and run into somebody that you know, and they're like, we're trying to withdraw their husband at home from alcohol, because who wants to come in and be like, I'm trying to, quit drinking, and nobody knows that I've been drinking this long, and then they get really sick at home alone because they probably went cold turkey. Okay, so preferably when you're managing someone that's been on alcohol, or especially benzodiazepines, because they kind of work on the brain the same way. Most any of this stuff can be addictive, but those really, you want to taper the patient off, have them monitored real closely while you're tapering it off. And a lot of times, part of the orders are giving them something that works like a benzodiazepine, some sort of medication to help ease them down as you work them through the withdrawal. So just know that withdrawal from alcohol can be really dangerous. It can end up in death, and seizures. Sometimes they'll be at home and they'll try to quit and end up having some seizures. Sometimes if you're at the hospital, if you've got a patient that's been drinking for a really, really long time and they need, like, say, valve replacement or some sort of heart surgery or something they really need, the doctor may just prescribe a certain amount of beer every day for them instead of trying to work them through a full withdrawal. So the supervisor will go buy some beer and you keep
Put it in the cooler.
in your bedroom. And and they just get their beer at a certain time of day, or at a when you see your supervisor going back. So, it's always good to be honest with your provider, and you want your clients to be honest with you, because you could be taking care of a post-op patient. Is when it comes up a lot. Someone ends up hurting their knee or something, and didn't plan on being in the hospital, and about 2 or 3 days in, you start to see these symptoms, or all of a sudden they're just really confused and hallucinating. You might want to check, how much, you want to make sure you're getting a good assessment. Fine. And a lot of times they may just not feel comfortable telling. So some of the meds that are different in this chapter that are new. You've got your meds like antabuse, your alcohol deterrents, sometimes someone that's been through alcohol, a drug and alcohol withdrawal, especially alcohol, they may be prescribed Antabuse. And if you drink alcohol when you're taking it, it makes you
taste nasty.
sick and vomiting and all. I had a family one time, we were like, so how you doing? Doing good, not drinking as much, great. Doctor put me on this medicine. Yeah, Antabuse, yeah, how's it going? God, it makes me sick when I drink. Yeah, you still drinking? Yeah, it's getting better, awesome. That's not the way it's supposed to work. It's not what it's supposed to do. It's supposed to be a deterrent, not something you work through.
They wanted it bad.
Uh-huh, yeah. It was just another challenge to overcome, you know, but, So some of the other meds that are new in here, anticonvulsants, especially carbachylate. They may be getting this medication during withdrawal to help keep them from having seizures, keep that nervous system managed while you're pulling all that alcohol away from it.
What was the name of the medication?
Carbamazepine. And it's in your syllabus, and if I could pull it up, I would.
It's on page 98 in the book.
98 in your book, thank
In the
you.
API book.
Hypnotics. A lot of times Librium is used for withdrawal. Okay, some of the other drugs that you see with addiction, central nervous system stimulants. Those are like cocaine and crack. We hit briefly on several different categories of drugs in this unit. You need to know the general effects that each of these categories has on you, not get all in the weeds with each one of them. But the bigger focus being on alcoholism. Crack and cocaine are stimulants. Usually if you have somebody come in the hospital and you're taking care of them, they're very high strung. If they're pregnant, they're probably if they're anywhere near term, it can put them in labor, real violent labor, abruption, bleeding. They're very nervous. Withdrawal, signs and symptoms of somebody that comes in with you withdrawing from stimulants. Fatigue, depression, agitation. Lethargy, craving. And if you look on each one of these in the slides in your PowerPoint, it also mentions treatment. And in there are your medications. Covers most of them though. Antidepressants and dopamine agonists. Opiates. Probably one of the bigger problems you're going to deal with. Opium, morphine, heroin, fentanyl, methadone. Signs and symptoms of use: constricted pupils, low respiratory rate, drowsy, slurred speech. Signs and symptoms of overdose, respiratory depression, coma, seizures, death. Treatment options. You have methadone.
Isn't that given for people coming off of like heroin or
Any
crystal
of
meth?
these opioids. Any of these opioids, yep. Methadone clinics are real highly, lot of oversight with methadone clinics, with the doctors writing those prescriptions and monitoring them. And basically, you're trying to work them through coming to the addiction by giving them the methadone, and then they get addicted. And then Suboxone is another,
Bad one.
yes, pulling a baby off Suboxone is the hardest thing in the world. I'd rather.
Don't they
I
tell
think
them
it just
like,
makes me
even if
nervous.
they're pregnant and they can't quit cold turkey, they still have to take it and they get you can give it to the baby?
You're gonna have to manage the baby,
Yeah.
yeah. So you have, and from what I understand, I mean, this is not exam stuff, but there's different regulations on Suboxone clinics than there is methadone, but you may see clients on both.
There's,
On both of those medicines?
yeah.
Oh,
I
my
know.
I mean, no, not both, but you may
Oh,
have a client come
either
in
one.
that's taking Suboxone, or you may have somebody
Come in,
that's doing
okay.
methadone.
I was like, they're taking both of them?
No, well,
But I know
Whoa.
there's, at least here in the Gulf Coast, there's physicians that do it. It's normally for Suboxone, all cash, and it's done separate from their employment.
oh.
There's,
When I went to work
I mean,
in New
it's-
Orleans, I had
it's
really
known that
never
they do
heard
it.
of Suboxone until I went to, and now you hear it here. But when I went to New Orleans, you hardly saw Suboxone on the coast, but when I got there, that was one of the biggest issues they were having in NICU because of the heroin use in New Orleans.
It's supposed to be a 6-month treatment, but at maximum 6 months, but there's people on it for 6 years.
That's one of the few times I almost got beat up, but somebody wanted it. She'd lost her prescription or something and wanted us, she almost came over the counter, but,
And what do you do in a situation like that? Call security?
well, her mom was with her, you know, and it was like, we can't write prescriptions. I can't write. That's why emergency rooms used to, like, 8 years ago maybe, if a client called the hospital and said, I went to the emergency room and I had whatever it was, and the provider gave me a prescription for Lortab, and I lost my prescription. Back then, they could almost go in and somebody write another prescription, you know. And as risk manager, I took that call a lot, you know, hey, and then you go talk to the provider, and then all of a sudden it's like,
Or they could call in over the phone.
yeah. And you could come in and get, you know, 10 days worth of some medication because, you know, you gotten hurt. And now you go in emergency rooms and it's the whole guidelines.
I broke my 800.
Some of them may not even write a prescription for an opioid. And then y'all, I don't know if y'all were at M&A when they talked about the new prescribing guidelines. It's like more than like 2 days worth.
3.
They're recommending you go to a pain management provider. So opioids, highly addictive. Now, when you're using,
But then you got some that still just want to push them on you too. And you're
Well-
like, no, I don't need them.
Now, using them in the hospital, if I'm recovering somebody from major surgery, I want to give you Demerol or something good. You know, I don't want to give you something. They work great, you know, but I want to move you to something else.
Pretty quick.
post-operative, you know, but get you through those first couple hours, and nothing else is really going to work. So opioid is a treatment plan in itself. It also goes into marijuana, hallucinogens, inhalants. Just want to briefly, you need to just briefly familiarize yourself with the effects those have on a client so that you can recognize it. Inhalants, that one is so vague, and you may still have, you know, you may still have patients that are inhaling the computer cleaner or
Candy or
puffing spray paint,
CFCs.
good
What'd you
old
say?
spray paint. The problem with that is it binds with, well, we don't need the whole thing. The problem with inhalants, it gives you euphoria, you can have hallucinations, enhances sexual pleasure, you'll see giggling, laughter. The signs and symptoms are sudden death.
Imagine that.
And it's kind of a crapshoot because you can't dose it very well. So weakness, loss of balance, numbness, treatments. If it was an organic solvent, there are no antidotes. You just supportive management of the client. A volatile nitrate, there you could give methylene blue and oxygen. If it was inhaled anesthetic, for treating neuropathy with B12. Then you get your club drugs, ecstasy, MDA, MDE. And those effects of those club drugs are kind of subjective, but they do tend to resemble stimulants and hallucinogenics. Then you have date rape drugs like Rohypnol. It lowers your inhibitions, makes you very relaxed, relaxes your voluntary muscles, and gives you amnesia from when you took it, like Versed. Meth, we had a really good video. We may still try to pull it up on break. Methamphetamines, highly addictive. The first meth patient I ever saw too. I'm so old, we didn't have meth. We had a client have a stroke. It was
I
pregnant.
think somebody's cooking it.
And then we were like, did they do any drugs? Because they said no, and she had a stroke. And the family's like, oh, she's doing some drugs. It's something they make at home. And we're like, what? And they were like, they make them at home. They use battery acid, like Sudafed. And I was like, because we were already in shock. It was a friend of mine's patient, and she's like, yeah, she looks like she's had a stroke. And we were like, we went in the room, did a whole workup, and we were like, come out. She looks like she's had a stroke. The doctor's like, she can't have a stroke. We're like, looks like she's had a stroke. So the doc went in, they called neurology. The doc came, he's like, send her down for a CT now, and she had had a stroke. And so we went back in to explain it to the family, and then the family was telling us all about this drug, this new drug they're doing, and they didn't know what it was called. And they used battery acid and Sudafed and something. And we were like, stop. What? And that was the first time, and then after that it was just like,
Bam, it's everywhere.
everywhere. So if we're treating someone with an addiction to any of these chemicals, what's the main thing we have to have for it to be effective?
Naloxone.
What's the main component we need? What's the main factor with the patient or the whole situation to get them to stop with the addiction? They have to want to. They have to want to. Now, we can take care of an acute overdose. We can take care of them coming in the hospital. We can manage them. We can manage the withdrawal, the
But we
delirium.
can't make them quit.
Right, but as far as discharging them home,
We have to accept desire.
yeah, putting them in a treatment program, we can find them, but they have to want to withdraw. Couple of page numbers, speaking of the detox and the withdrawal, table 22.5, page 422 in your book. Okay, so we've got the client and we're detoxing them or withdrawing them from the alcohol. You want to make sure you look over that. 422, table 22.5. Signs and symptoms. No, I don't have a computer. someone in the hospital and they want to stop drinking and you start to manage them, this walks you through the signs and symptoms. Usually they start in about 6 to 8 hours. A lot of your signs and symptoms are like high blood pressure, abdominal discomfort. Occasionally, in a small percentage of clients, you may end up with delirium tremens, DTs. And that usually starts about 3 days in to being off of the alcohol. They could be hallucinating, having a irregular heart rate, so you need to be assessing them for these things. It could lead to seizures and death, but it's not in but a small percentage. But you hear people talking about DTs. Again, this is usually the client that, if you know they're withdrawing, that's great. It's all of the clients you're taking care of that you didn't know had an addiction, alcohol addiction, and 2 or 3 days in, they start to have these problems. So some of our intervention strategies, how we can help this person. The process with drug and alcohol withdrawal is detox, get the chemicals out of their system, get them back to baseline, and then start the rehab. And, you know, the rehab programs, it depends on what they can get into, how many weeks or days they stay, or months. Then after rehab, depending on how they're doing and the level of addiction, they may go straight from rehab into outpatient therapy, or they may need some sort of in-between, like a partial hospitalization. Like we talked about in Unit 1 and therapeutic modalities. The client that's doing okay when someone's home with them and they're not drinking, but if they're left alone, they may relapse. So this person may check into the hospital part of the day and come home. Or they could live in a halfway house where they're with a group of individuals that are kind of sharing the same situation, and with someone there kind of overseeing them, a little more oversight, making sure they're keeping their job, you know, not relapsing. Encourage them to join groups like Alcoholics Anonymous, or whatever addiction it is. Your main goals when they are in rehab and moving forward is to prevent a relapse. When you're taking care of these people, they're struggling with some depression, all sorts of challenges they have going on. So the nurse needs to be able to care for them in a non-judgmental way, build a rapport with them. They need to trust that you're genuine. I always say if I had, you know, work in OB, well, in mental health, you come across people with addictions and all, and some people are just like, I just couldn't take care of that patient, you know, that's pregnant and whatever, on cocaine. But as the nurse, well, A, you have to, but B, it's almost like you recognize, almost on a subconscious level, if I don't treat this person like this, establish some trust, non-judgmental, genuine behavior, and like we said in Unit 1, I don't have that, like I like them or anything, but I have to treat them with some interest and treat them as an individual. I may be the first person that's treated them that way. And in order for them to want to go through all this rehab and treatment, they have to have improvement with their self-esteem, and they have to want to do it. So, genuine caring approach from an RN might be the thing
That they needed to get them to do that.
They needed to say, I'm worth this, or my child's worth this, so I'm gonna do it. So in here about the genuineness, the building the trusting relationship. When you're in the role of the nurse, you're there to perform something, and it's the best approach. Okey doke. Impaired nurses. Right? Give me 5 minutes. Yeah. Impaired nurses. We talked about this briefly. When we talk about impairment and we talk about diversion, you're going to hear diversion. That just means you took a controlled substance and you diverted it from where it should have gone to somewhere else, okay? So like we said, your manager doesn't have to prove you stole the medicine. The manager just has to show that you diverted the controlled substance from where it was to where it should have been. I pulled out a vial of fentanyl and it should have gone to the patient in the operating room. I had to see it go in that patient in the operating room. Even though the CRNA gave it, I can't just, hey, you're going to put Miss Six to sleep, here's that fentanyl, and walk off. I'm walking off from my license when I do that. Who can hand off narcotics like that, controlled substance? Who can take a controlled substance and give it to somebody and not know what they do with it? Pharmacists, right. That's the role of the pharmacist. Who else can do it? Yeah, well, yeah, the drugstore, because they get you to sign it out, they're done. The provider can write a prescription, and you can do whatever. Me, as a NARN, not an advanced practice nurse, I just can take the controlled substance and watch it go in you. I can hand it to the anesthesiologist, and he can do the epidural, but I see him do it. Have you ever handed it to an anesthesiologist and they gave it to themselves? In the operating room? Behind the curtain? Yeah. So,
Then how do you do that?
huh?
How do you do that?
Yeah. They say one of the
That
worst.
happens often.
Yes.
Huh?
We had a provider that was diverting. And back in the day, it was just like going for an operation. I need some Demerol. Well, here's the Demerol. But they're behind the drape. I'm scrubbed in. I didn't see, So the estimate is 10% of abuse in the general population. So at least 10% in a hospital setting.
In a medical
You
setting.
would like to think it's way less.
But it's not.
It's probably way more.
Because of access, right?
Access, stressful environment, type A personalities, a lot of money can change hands. Because it's not just nurses, there's pharmacy techs. Pharmacy techs, when you see them going down the hall with that cart, they got about $30,000 worth of Dilaudid in there. Even if people aren't using, that's why I say we're talking about diversion. We're not talking about addiction. You could just be selling. And sometimes they've come and just pulled the whole unit and said, it's time to come do a drug screen. You clock in and they're like, and you have to go in front of the nurse and tinkle. And you catch somebody else doing something you didn't catch the person you thought, because they probably weren't taking it, they were probably selling. So anyhow, let's direct it to what does the impaired nurse look like? About 10% of nurses abuse drugs and alcohol. The warning signs, what do you think the warning signs are?
Excuses.
We're volunteer,
Yeah, they want to work all the time.
always
That's,
leaving.
and a lot of times it may be the best nurse on the unit. They'll always want to help you. Hey, you want me to do that discharge for you? Sure. Interrupt you while you're in the Pyxis. You're in the Pyxis doing stuff. Hey, what are you doing this weekend? And you're trying to, oh, good, everything going, yeah, and you're just talking. And what do? You forget to log out. They lured you right into forgetting to log out, and then they just ease right into that Pyxis behind you and pull out a Demerol on everybody on the floor. So they're real helpful, they're real friendly, they work overtime. It's real sad. It's real sad. Mhm.
CNAs, is it the same as the anesthesiologists? They don't have to have someone else.
CRNA, those are advanced practice nurses. They're a little bit different and they can prescribe. And sometimes we work collaboratively with the CRNA, but if I hand it off to you, I need to see you give it. But they can withdraw, they can take the drugs out of the Texas themselves. They can just bypass me all around, and that's kind of what we all went to. Used to, anesthesia just walked from the floor and said, can you, I need some Sudafed and fentanyl for the patient in room 5, and we were the ones pulling. And then that all changed too. Everybody
To keep you
has-
from putting your license on the line for
and yeah,
them.
and just to cut down on the people touching it. Whoever's using it needs to pull it out. So this person is very helpful, usually works a lot of overtime, and it's not usually who you think it's gonna be. They may be leaving the unit a lot. Hey, can I take another break? Hey, I need to leave. I want to finish this before we come back. I'm talking about the patient, the nurse. They want to leave a lot. Their patients complain of pain a lot. And
They shouldn't be in pain because they should have the med, but they have.
patients not getting the pain medicine, they are.
Get
So,
saline.
yeah, or half as much.
Bravo.
The drug counts are off. Or they're the person that says I dropped them on the floor, or the patient didn't want them. I took them in, I need to waste these. We literally kind of walked through one time in a hospital and asked the nurses, what's the process for wasting a narcotic? Oh, I just signed the line. I signed that form. And we're like, no, what's the process? Well, I signed my name. But yeah, but what do you do? Sign my name. And we're like, no, you watch it be wasted. You watch it be wasted. So
Yeah, don't you have to have somebody
you
watch
gotta
you do
stand
it?
there and watch you see it. Let me see it. Let me see the
God
vial.
forbid if you don't, they're gonna chase you down and find you.
Yeah, not this, hey, I wasted this a minute ago. Will you sign my waste? What do you say when somebody says, hey, Haley, I wasted this Demerol a few minutes ago. Will you sign behind me in the picture?
Nope,
Oh, come on. I was busy.
you were
You're gonna
busy.
sign behind me?
No.
God. You know what Haley did? She wouldn't sign behind me. What does Haley do? You keep that chin up. You don't do that. And you'll see units where they're like, oh, we all work together really good.
So they're all doing it.
Oh, come on. When I work the other shift, they sign behind me. They'll pull it out for me and give it. Well, that's fine. I'm not. Will you pull that Ativan out for me? I'm just going to run down the hall. It's an emergency. I'll go down and give it for you, but I'm not going to give it to you. Well, golly. So, substance abuse is apparent in the hospital. If a nurse came up to you, we'll finish up before the break. If a coworker came up to you and said, I've been having some problems at home, and whatever the case, and they confide in you that they have an addiction problem and they've been diverting or whatever, as an RN, go read the Nurse Practice Act. The Mississippi Nurses Association is not like our sorority or fraternity or something. They are a public service group. The Mississippi Nurses Association is there, the Board of Nursing, not M&A, the Board of Nursing is there to protect the public. So, our laws say that we're here to protect the public. So if your friend tells you that, and they're another RN, we're obligated to report that. Because if you find it out, and then you don't tell it, then there's two of you that have problems, okay? So the conversation you would have to have, and hardly anybody's ever going to tell you this, but if they do, you would say, there's help for you. The Board of Nursing will help you get therapy. The detox, the rehab, the follow-up, they will put you into a recovery program. They'll make sure that somebody you work with is a mentor for you, and they will help you get back on track, and they'll let you keep your license. They may take several years letting you work like somewhere where you're not around controlled substances, But you don't have to lose your license over this. But if you don't tell, you're gonna have a hard time holding on to your license. And you gotta tell them, if you don't tell, I'm gonna have to tell. You need to go tell our manager. And that's all you can do. And if you suspect it, you have to report it. And then like as a director or a manager, if I stumbled across it, I had to pull the nurse in and say, you know, we've been looking at your drug usage report. Pyxis and Omnicell ran all sorts of statistical reports on you. And you're so far outside the norm for drug usage on the unit, I need to talk to you about what you've been doing. Oh, well, I work recovery room a lot, and we used a lot more. It accounts for that. You're still outside the norm. I just need to let you know we're going to pull some of your charts and look at what you wrote, see what you've been doing. That's opportunity if you are doing something to say, you know what, I have a problem, I need to self-report. If I catch you and we terminate you because you diverted the drugs, stole them, or didn't do what you were supposed to, didn't follow the policy for how to handle them, then that conversation goes, we're going to go ahead and have to let you go. You didn't follow our policy, you mishandled a controlled substance. I'm going to have to call the board of nursing and report you. I'll give you till tomorrow afternoon at 4, because it would be a lot better with the board if you would go ahead and call them first. And they all say, okay. And then you call the board the next day at 4, and a lot of times they didn't call. Then the board follows up with them. Then you get the hearing and all. So, and then you also have to call the board of pharmacy and say, we had an RN that was diverting drugs in the hospital. And the board of pharmacy may come down and see, well, what is your process? How come you can't keep up with these drugs? If you don't report it to the board of pharmacy and the board of pharmacy finds out, then they can take away your license to distribute controlled substances. And at that point, you no longer have a hospital. So that's kind of how all of that goes. You won't have real in-depth questions on that, but you do need to know how to respond to a peer. If they tell you they're using narcotics, you need to tell somebody. Yeah, it's okay to say, oh, I'll help you, and if you want to go to rehab, that's all great, but the key thing is they need to report that to their manager. You have got to let somebody know. So now we can take a break till